Hi, everyone. I'm Derek Spencer, Director of the Focus Program here at Gilead Sciences. Gilead remains a committed partner in the global response to end blood-borne viral epidemics. We want to express our congratulations to the organizers of this international Fast Track City Conference. Though we can't be together in person, I believe there's a lot we can learn from each other virtually. Screening, diagnoses, and linkage to care are essential components to our strategy to achieve the initial steps of our UNAIDS 90-90-90 plan, in addition to our global efforts to address hepatitis C. A broad array of testing approaches is vital. Targeted screening for vulnerable or need-to-reach populations, a new look at the possibilities of self-testing, routine policy-driven screening as the community accesses services, something my European partners calls opportunistic screening. They're all needed as we successfully achieve public health goals. This session is going to highlight resilient HIV and hepatitis C routine screening and linkage to care frameworks with conversations from providers on the front line in Portugal and the United States. While our work has always been important, it is even more urgent today as we confront the global pandemic of COVID-19. Shelter-in-place policy, community fear of contracting COVID-19 during a healthcare encounter, redeployment of HIV and HCV public health staff during this crisis with budget shortfalls, cost containment, and other austerity measures have all greatly challenged our work. We want to send a clear message, a message that we must continue to invest in screening, diagnoses, and linkage to care for hepatitis C and HIV. The public health cost of late diagnosis is far too expensive for the individual in terms of increased morbidity, illness, mortality, death, decreased productivity, and just the simple loss of caring for yourself or someone that you love. For the public, the cost is great too. Increased risk of transmission, and quite frankly, not only the uncontrolled cost of late diagnosis, but the downward spiral of fear, illness, and stigma that each of us has worked so hard to eliminate. Today, you'll hear some examples of emerging and best practices to address HIV and HCV screening and linkage to care in the era of COVID. But first, let me tell you a little bit more about Focus. Gilead's Focus program enables partners to develop and disseminate best practices in HIV, HBV, and HCV screening and linkage to care. It's all done in accordance with regional and national public health guidelines and recommendations. We've partnered with hospitals, community health centers, health departments, community-based programs, and others in cities across the US, Portugal, and Spain. We've conducted over 11 million tests to provide diagnosis and linkage to care for bloodborne viruses. Focus has a simple model, and it's an acronym, and it's TEST. T stands for testing that's integrated into normal clinic processes and flows. We use existing staff and infrastructure to create greater efficiencies. E stands for maximally using the electronic medical record. S stands for stakeholder engagement and systemic change for sustainable approaches. And then finally, T stands for training using continuous quality improvement and data so that you can evaluate your program and get information to your institution and to other institutions that need to understand your work. As we strategize through the COVID-19 pandemic and this year's pending flu season, we're going to need models that allow us to maintain vital screening and linkage to care for bloodborne viruses. Let's visit a couple of our partners to learn how they are applying this model in their healthcare setting and also in community to transform routine HIV and hepatitis C screening, even in the era of COVID. Come on, let's go. So, hi everyone. We're now virtually in Chicago, Illinois. We're here at the University of Chicago Medical Center. It's an academic medical health system and level 1 adult trauma center here in the region. You're about to hear from 2 medical staff that led efforts to integrate HIV screening and linkage to care into their newly developed COVID ER. I think it's significant to note that they did this at the height of the pandemic here in the US. They recently wrote about their experience in Notes from the Field in AIDS and Behavior this spring. The publication is entitled Routine Screening for HIV in an Urban Emergency Department During the COVID-19 Pandemic. We couldn't find better partners to exemplify the first two components of the focus model. If you recall, the first component of the model is T, and that stands for testing. Testing for HIV was successfully integrated into normal clinic processes and flows during the COVID pandemic. And then secondly, E, which stands for EMR, shows us how you can maximally use the EMR to make your program successful. We're really fortunate to have with us here today two of the staff. Dr. Kimberly Stanford, she is a specialist in emergency medicine and co-PI for this project, and she's the assistant professor of medicine. Dr. David Petrick specializes in infectious disease. He is a professor of medicine and chief of infectious disease at the university. I want to welcome both of you, and we're really excited to have you. Dr. Stanford, I want to start with you. Talk to us a little bit about the role of the ED in screening and linkage to care for HIV. I think for some of our global partners, that's not necessarily a common practice to do screening and linkage to care for bloodborne virus, particularly HIV and ED. And then secondly, why it was important for you to continue your efforts to screen for HIV, even amidst a COVID-19 pandemic.
Sure. So we believe that the emergency department is a really, really key place for HIV screening. Our patients in particular, but patients everywhere, largely use the ED as their main source of care. Oftentimes, especially in our community, they don't go to primary care clinics and they prioritize the ED for their care. And so this is our best opportunity to catch them. And if we make it routine, then we make it acceptable to everyone. And so we feel like this is a really important service for our community to catch them in a place where they actually go for the majority of their care. And in terms of the COVID epidemic, we felt like patients were going to continue to utilize the ED, but as primary care clinics were shutting down, as STI clinics were shutting down, we became an even more vital resource for them, as often their only way of getting tested. And although a lot of people, most of us were focusing primarily on COVID and trying to respond to that, HIV wasn't going away. And so we wanted to make sure that we didn't lose that service for our community during that time.
I think that that's so significant. In the United States, and I would think in many places globally, between March to June, much of our community-based screening kind of came to a halt. There was shortage of PPE, there were redeployment of public health staff and shelter-in-place policy. If it were not for some of the screening that was happening in our EDs, we wouldn't have had screening for HIV. So we really applaud your efforts. This article is fantastic, your work is fantastic, but this could not have been an easy feat to pull off. How did you convince staff at the University of Chicago to get on board with you? And in the midst of the some of the pandemonium that was going on with COVID-19, how did you get everybody on board?
Yeah, so that's a great question, and it's kind of got a two-part answer because we had the first step was getting the screening in place, which happened before the COVID pandemic ever even started, and that actually did require quite a bit of work to get staff on board to do it. And that the majority of what we did to convince people was really education. It was going to speak with nurses and physicians and nurse practitioners and explaining the reasons why we were doing this, explaining the importance to the community, explaining how many patients we had found already and why this was necessary. And we really made a huge effort to do that. We continue to provide ongoing education. So every month feedback about how they were doing, how many people were being tested, some positive outcomes, giving them positive reinforcement for what they were doing and addressing their concerns. And that made a huge difference. And then during COVID, we set up a separate area of our emergency department that was to screen and treat patients that were suspected to have COVID. And so when we did that, thankfully, we had the support of our ED leadership to build in testing for HIV into that area. We had very limited ability to do any other kind of testing, but we built in a station to do HIV testing there with the goal of just making it as easy as possible. So I think lowering the barriers to testing, making it so that it was automatically flagged in the EMR, and that the nursing staff knew about it and it was easy to do, I think, was the key.
Yeah, you are touching on so many valuable tools for that can be replicated as we face, the future that we're dealing with COVID-19, and just basic principles for screening in healthcare facilities. We talked about testing being integrated. We talked about EMRs, but you also were really heavy on stakeholder engagement to involve the right people. And then finally, the training and engaging the right staff and getting the right people who are stakeholders. So this was turned into more than just you and Dr. Petrick's project, but it was the institution's project. And so I'm starting to understand your success more. I hope it's helpful for persons. Talk to me about the electronic medical record. How did you use that to facilitate your success?
So I think without the electronic medical record, without the changes that we made to the EMR, this would not have been possible. Our EMR, we redesigned it so that it automatically flags patients who are eligible for testing. And it flags them at the time of initial triage, and it offers a pop-up screen for the nurse who's doing the triage, and the nurse can then order the test without a physician being involved. And so that really streamlines things because nobody has to review the medical record, no one has to check to see if the patient qualifies for testing. It's already done for you, and it just makes it extremely easy. And then that pop-up continues to show up for both the nurse and the providers until somebody orders a test or declines the test for some reason. And so it kind of continues to subtly remind you, which I think encourages people to do the testing, but it takes the work out of it because you don't have to go then review and see if they, should be tested or not.
Yeah, no, that's a secret to success. This can't turn into another thing for our staff. So it has to be kind of integrated in normal clinic processes and flows. And it's a great use of the EMR. Dr. Petrick, I want to get you in this conversation. Share with us some of your findings, specifically on HIV diagnosis and linkage to care. They were significant.
Well, when we first did our report, we had diagnosed 2 patients with acute infection early in the period after Illinois had its stay-at-home order.
Yeah.
But since that time, with COVID still circulating and with a lot of testing going on for that, the numbers have increased even more. So in prior years, 2016 and 17, we had identified 7 acute patients in a year. 2018, only 4 patients.
Wow.
And then 2019, 7 patients again. But this year, we've already had 9 diagnoses for the year. 7 of those have come since that stay-at-home order. And we've always considered the acute patients to really be a priority. We try to get everyone linked to care rapidly and have rapid starts for antiretroviral therapy.
Yeah.
But I think this is really a priority with the acutes due to the extremely high viral loads, and both for a public health measure, but also it benefits these individuals. There are potential clinical benefits to starting early as well. So one thing is the ED has done just a superb job in doing the screening.
Yeah.
I think one thing that helps is the staff also knows, though, that there's a system in place that if someone does test positive, another team is going to take over with the notification and linkage to care. So we get a daily list, a daily mailing with any positive patient who tests, acute, chronic, and then we go ahead and find out if it's a new diagnosis. And we have social workers, including our program manager, Jess Schmidt, Michelle Taylor, who contact the patients by telephone, actually. They do the notification. There used to be some concern that phone notification may not be the best way to do this, but it really expedites this, and our social workers have so much experience doing this that they're able to really keep the patients calm let them know that this is the best thing that could happen. They got their diagnosis.
Yeah.
And then they're able to schedule them to see us for a visit within a day. Now, do we get everyone within a day? No, but we are usually linking patients within a few days.
Dr. Petrick, your results are standout. I think for the audience, I'm going to remind the audience that from Focus provides funding to partners, and we just do screening, diagnosis, and linkage to care, and then we fully stop there. We appreciate that our partners practice on a continuum. So, I listened to the data from Dr. Petrick, and he tells us about acute viral syndrome, acute cases in 2018 and 2019. Why do you think that we're seeing more cases of acute HIV syndrome during a pandemic?
So I think one of the interesting things about COVID is it's bringing people to the hospital seeking care who might not otherwise have come. So people who otherwise would have thought, oh, I have the flu or I have a cold and stayed home. Now they're so scared that they might have COVID that they're actually coming to the hospital to seek care. And as a result, this is our opportunity to screen them for HIV. And oftentimes now we're finding acute HIV cases in these suspected COVID patients. So this is, I think, highlighting why it is even more important than ever to continue our ED screening efforts.
I could talk to you all morning. For sake of time, I'm going to come to a close, and I just want to say the integrated workflows you described for screening of SARS-CoV-2 and HIV, they represent the type of innovation that is needed to accomplish our regional, our national, and global efforts to address the epidemic of HIV. So to Dr. Stanford and to Dr. Petrick, thank you for leading the way. Thank you so much. Hello, everybody. It's great to be back virtually in New Orleans, the Big Easy. I'm here with Crescent Care's Chief Operating Officer, Reginald Vicks, and their Counseling and Testing Manager, Joseph Olson. Our viewers should know a little bit about Crescent Care. They have a rich history in the greater New Orleans area. It was founded 40 years ago as the No AIDS Task Force, and for much of those 40 years, they were an AIDS service organization. And we'll talk about a little later why I think some of those skills as an ASO have really served them well as they have adjusted to the COVID-19 pandemic. In 2014, they were designated an FQHC. Reg and Joy, I reviewed some of your data from October 2019 through July 2020, and your screening volumes, like the rest of the globe, rapidly declined in February and April at the height of the pandemic. But in May, you begin to recover and you stabilize. To both of you, how did you integrate COVID-19 screening with HIV and hepatitis C?
Yeah,
go ahead, Joey.
So I think it in part had to do with our quick response. Our chief medical officer actually had us working from home with the leadership team, kind of got Crescent Care all working from home. I want to say even like 4 or 5 days, basically a working week before the city announced shutdowns and that we should be working from home, if at all possible. So we were kind of ahead of the curve on working from home and already had people working on like strategies for making work happen remotely. Yeah. So we were already starting that trend of like figuring out how we could continue work and serving the community while, stay-at-home orders and social distance orders were in play. Then there was, we very quickly became and maybe Reg can talk to this at some point too, we became a site for COVID screening in the community. We turned our garage, it's an open air garage, accessible by the ground level, into an open air COVID screening for the community. And so we were open that way, even when we weren't doing any HIV or HCV testing. And so part of the evolution of everything that we're going to talk about today started happening was because of that. We had people on the ground kind of understanding what the community was asking for. And then we found ways to integrate it based on those conversations. I'm happy to talk a little bit more about the programs that came out of that if you would like.
Please do.
Yeah. So once we had the COVID screening up and running, we were able to, I think one of the key things that helped us integrate was the staff knowledge of programs. In general, pre-COVID times, we have a staff who are great at managing things across the prevention department specifically. We can do community testing events. We have the syringe access program. We have clinic testing, and people are cross-trained across those programs.
Yeah.
So when COVID hit, and we had to quickly shift focus from some of those things, it was easy to make that transition. People had the time, people were flexible generally already. And so, for example, I jumped down into the garage for the first three and a half months of the pandemic, and was helping with COVID screening. And because I was down there with some of my team, we ended up having conversations with people who were still coming into the clinic for their regular HIV testing. And we had to, for several weeks, tell them that we didn't have that available anymore. But we knew that people were still coming in despite the stay-at-home orders, despite information being on the website that we weren't open for business as usual. People were still coming in because for STIs, people still need those services. Those things haven't changed. And
I think it is so significant that you press us when you talk about integration. People just think about testing, but you integrated your staff's knowledge and kind of cross-functionality of knowledge of your staff to deal with this epidemic and this pandemic.
Yeah, that's exactly it. We were able to integrate that. And then that's how we started our at-home testing program, was because we knew people were coming in and asking for it. And so we were able to, this kind of ties into our second way of integrating, is talking about program funding and finding pieces across grants. We're funded by the state, by the city, through Focus, through some other funding sources. And we're able to talk to those partners and figure out how we can pay for different pieces of bringing programs back that weren't part of the original conversation, when we got these grants. So talking about where we can spend money on PPE, talking about how we can find money for at-home test kits to get to the community, since we can't do the test kits ourselves on site. At that point, we've found ways to integrate that too now. But that program funding and partnerships with our funders was also a key thing.
Absolutely. Absolutely. And one thing I'd like to add to that, or rather emphasize, is that collaborating with partners was a huge piece of this process for us to create an integrated model under pandemic circumstances. And so we intentionally reached out to all of our partners and started developing plans to make sure that we could comply with pandemic restrictions and orders, but also to find out where clients were located. One example of that is our outreach to the homeless. In New Orleans, many of the homeless were put up in hotels and other locations. Obviously, the hotels, weren't occupied. And so it was an ideal opportunity. And in collaboration with two of the medical schools in the city, primarily Tulane Medical School and Unity for the Homeless and some other partners, we were able to facilitate outreach in those hotels to get to our homeless population. And the medical students actually helped facilitate administering HIV testing. And some Hep C testing has also taken place with our homeless population that we could reach. So that collaboration with partners has been extremely important.
Joey and Reg, we're coming in for a bit of a landing, but I think it's important to talk about telehealth. Like, what role has telehealth played in your ability? You've been able to really pre-COVID and post-COVID get people linked into care pretty quickly. What role has telehealth played in your organization?
So telehealth has been significant. Many organizations across the country were essentially pushed into standing up their telehealth platforms quickly. And the manufacturers of the electronic health records of various types were also nudged vigorously to support standing those services, that technology up very quickly. And it's really had a great impact. because we were able to continue maintaining our contact with clients, working with them to vet their technology that they had available. I don't know if you recall, but the FCC put out a $200 million grant for technology improvements, and we were able to take advantage of that and actually procure some devices that clients could use who didn't have access to technology. They're deployed actually in their homes. The messaging that we could produce through our electronic health record and through telehealth services, encouraging people to get tested, to use at-home test kits, to stay in touch with their providers to remain in care. We actually saw initially a surge in compliance with staying in care and staying in contact with providers through the telehealth model. So that has actually been a game changer that we see in the future is going to remain because we can cohort telemedicine with in-person visits and really create a robust network around retention in care and access to care. So we see some great opportunity there, Derek, with engagement with clients in the community.
Yeah.
Go ahead, Jerry.
Yeah, I'd just like to add too, because it is, to echo exactly what Reg said, the moving forward, I see a connection between the past of the fast linkage model in person, but this telehealth piece is going to be key to provide the most options for the most people that get more people in the door. I know, so after the at-home testing started, we were actually able to integrate into our COVID screening down in the garage. We were able to have the providers start offering rapid HIV tests down in the garage as well. And between that program, the at-home testing, the hotel testing, and then we actually were able to start doing rapid testing as part of our routine screening appointments that were deemed essential enough to have someone come in for their labs. We saw, I want to say about 24 people since January. So the majority of them have happened since the stay-at-home order has been placed. 96% of them have linked to care. People who tested on the at-home test, we've had 150 test kits go out so far, and about just over 100 have reported their results. 2 of them were reactive, and they, even with the at-home test kit, still linked to care the same day. So like the fact that that happened under COVID is just really a tribute to the success of this integration of both telehealth and the in-person process working together and still getting people into care.
Joey and Reggie, it is so obvious that your roots as an AIDS service organization have served you well. The creativity that's typically associated with an AIDS service organization is serving you well as a leader in New Orleans, and now, one of the greatest disseminators for HIV and HCV screening. We experienced a drastic reduction, and in some places a cessation of HIV and HCV screening at the height of the COVID pandemic. We saw public health staff redeployed and many staff declared to be non-essential. But today you brought to us solutions. You brought solutions about what integration looks like. It's just not about screening, but it's integration of staff knowledge, cross-functionality, program funding just to make it happen. And then your engagement with community, which has always been strong, but that targeted approach for specific communities, and then that relationship you have in community, even with entities like the Office of Public Health. So I just want to say thank you on behalf of the country for all you do, the great work, and just continued great success in dissemination. Thank you for spending some time with us today.
Thank you for having us.
Thank you for having us, Derek. We really appreciate it.
Awesome. Thank you. So while it's been an amazing discussion with so many of our partners, we just virtually landed in San Antonio, Texas. And I'm not sure if the viewers know that San Antonio was the first city in Texas that was designated as a fast track city. We're visiting with Metropolitan Methodist Hospital to learn how they're creating systemic change. They're doing so in their hospital, they're doing so throughout their health system, and then they also are doing it in collaboration with communities. So we think there's some valuable lessons to be learned from this partner and how they've approached their work. Methodist is one of the largest health systems in San Antonio, and this region has been disproportionately impacted by HIV, by hepatitis C, and like the rest of the globe of late COVID-19. I'm here with Dr. Diana Henderson. She is the Chief Medical Officer for the institution, and which is part of the Methodist Healthcare System of San Antonio. I also want to acknowledge Sonali Sasina, who's a Focus manager and also doing a great work for Focus in that region. Dr. Henderson, thank you for being here. I know that Texas was incredibly hard hit with a surge of new cases of COVID-19, and then also unfortunately experienced a lot of death in the region. So how is the staff doing and how's the community doing?
Well, thank you for having me. Yes, it's really been challenging times. We say that we're not only treating an epidemic with HIV, but we're now fighting a pandemic. And so San Antonio has been hit hard.
Yeah, so this is such a challenging time, and there is a big debate in our country and really across the globe about whether we were prepared for this pandemic. And I don't want to tackle that necessarily in this session, but you implemented some changes in 2019 pre-COVID that allowed you to continue screening for HIV and hepatitis C amidst the COVID-19 pandemic. So could you just kind of talk about what are some of the things that you put in place that allowed you, when we all faced the shock of this pandemic, to still continue to screen for HIV and hepatitis C?
Yeah, so with our partnership with Gilead Sciences, we were able to really focus on what was important to our community, and that is HIV and hepatitis C. And I think with those shared values of integrity and excellence, really, that built the foundation so that we could build this process for routine screening and linkage to care. We have real buy-in from our internal stakeholders. Our hospital is in a downtown area, and we're very connected to our community. We feel that our community, our patients, we see at one point of their continuum of care, and when they're in our community, they are still important to us. And so we wanted to reach all of these people, and that's with the leadership that we have at our hospital. Senior leadership team, our CEO, our medical staff leadership, both in the emergency room, all of the areas. And so when we first started talking about this initiative, I wasn't pulling anyone along. They were pushing me, saying this is really important.
Wow.
And I think it goes along with San Antonio as being designated as a fast track city. And we have the buy-in from our Metropolitan Health District, our city, our county. They coming to us and saying, hey, we have a problem here and we need your help. And so along with that comes your community-based clinics. Again, just stepping up to be partners with us. And what is really exciting is because, I feel, I guess, fortunate at the time that I wasn't dealing with COVID when we set this up.
Yeah.
Setting up our process, our policies, everything that we could put into place so that we can follow the guidelines of the CDC in providing routine screening and linkage to care. And so it started out in November of 2019. And as of May of 2020, we've conducted over 10,000 HIV and hepatitis C tests. And we've diagnosed 339 patients with HIV and hepatitis C combined.
Dr. Henderson, those are impressive. And, for a busy staff who's working amongst the pandemic, there's really not a lot of opportunity to celebrate some of the gains that you're making as an institution, but that is such an offering to public health for your region and also for the nation. I also think that when you talk about stakeholder engagement, you guys have a bit of a model there. I mean, you talk about, you had internal stakeholders involved, but also external, and you seem to maneuver, the balance of that really well. Again, it speaks to this question of preparedness. Some of it has to do with what we do to establish the infrastructure strongly for even policy-driven screening that was able to withstand even a pandemic.
I think linkage to care is the strongest part of the program. And so what we did is going to those partners who were providing care and establishing memorandums of understanding, and so that we can confidentially share information when we contact the patient, is do that warm handoff to a provider, to a clinic. And we went and visited with the clinic so that we could see where patients are going. And we wanted to identify any barriers that we could for a patient coming into a system with a shocking diagnosis, and sometimes, and how can we get them connected. And so once again, very much a learning process for us.
Dr. Henson, any thoughts you want to give this audience in closing?
Well, I think in 2019, we really laid the groundwork for that routine screening and that linkage to care. And, we're proud of the fact that in the midst of a pandemic, we're still continuing to provide that screening and that linkage to care. I think there's going to be a halo effect of keeping patients linked to care in general, because there's such fear of COVID. And so I think what we have is a great system now that we want to build on our current processes and everything that we've laid there, make it through this pandemic, and continue to spread our processes through our healthcare system and have this impact on our community.
I'm smiling because your work really fully envelops the entire focused test model, that your testing is integrated in normal clinic processes and flows. You maximally use the EMR, the E, the S is stakeholder engagement. Wow, you did that incredible. And then some of the training and looking at data to make the decision about, finding 58% of your Hep C patients with chronic infection being outside their birth cohort. So we just want to wish you and your team continued success. When you're successful, public health is successful. So thanks again for your time and your work.
Thank you.
You're welcome. So welcome virtually to Miami, Florida. We're here on the front lines with some of the emergency department staff at Jackson Memorial Hospital. You're going to hear more about this staff and the great work this hospital is doing in the region shortly. We wanted to provide you some context really early to help you to understand a little bit about Florida and Miami. Miami is one of the hardest hit regions in the United States as it relates to HIV. And this spring and summer, it also has been very hard hit with COVID-19. This staff has done a fantastic job as it relates to the last T in the test model. That stands for training, continuous quality improvement, data and dissemination. And so you're going to hear much of their efforts as it relates to linkage to care for HIV. So stay tuned. You're going to learn some things that are going to help you for your institution. I want to introduce the staff, and I'm going to ask them as I say their name just to lift their hands so that you'll know who they are. I'll start with Dr. Lily Lee. Dr. Lee is the Emergency Department Medical Director and Chief of Emergency Medicine at the hospital. Secondly, there's Dr. Patricia Panakos, who is the Assistant Program Director of Emergency Medicine Residency Program at Jackson Memorial Hospital. And then finally, Monica Bahaman, who is a Program Director for the Focus Program. I believe that Patricia and Monica have been with the program since its inception. So I just want to welcome each of you and thank you I want to start off with Dr. Lee and ask Dr. Lee just to give us a brief overview of the Jackson Memorial Hospital. Dr. Lee?
Thank you, Derek. It's my pleasure. Jackson Memorial Hospital actually started as a 13-bed Miami City hospital in 1918 in the midst of the influenza pandemic. The mission has always been to serve all of Miami-Dade County residents with a single high standard of care, regardless of ability to pay. Since then, it's become one of the largest public and teaching hospital systems in the U.S.,
Wow.
with its major affiliation with the University of Miami Miller School of Medicine. It is currently licensed for 1,550 beds. It has weathered through the flu pandemic in 1918, multiple hurricanes, the polio epidemic,
Wow.
HIV and AIDS, and of course, currently the COVID-19 pandemic. It is the centerpiece of the Jackson Health System that is operated by the Miami-Dade County Public Health Trust. And as a system, we provide full spectrum comprehensive care to our patients: urgent and emergency care, primary care clinics, acute hospital care, long-term care facilities, and rehabilitative care. The Jackson Emergency Medicine Emergency Department serves over 120,000 adult and pediatric patients a year.
Wow.
Some use it as a safety net hospital. We provide primary care, but we provide also acute emergency care and comprehensive care in stroke and trauma. We also are active in education of medical students and residents and involved in research that are relevant and impactful for our patient population.
So I think, Derek, that with this, you can see the mission of the hospital together with the setting seemed like the perfect place to bring a focus program. Prior to Focus, our hospital was testing about 800 patients for HIV each year. And after we launched the program, we quickly scaled up to over 20,000 patients being tested each year for HIV and hepatitis C. We have found our seropositivity to be 2.4 for HIV and about 5% for HCV. Thanks to our screening program, we have also been able to identify over 30 acute cases, and most of these would have never been tested because they showed up to the ED with flu-like symptoms.
Yeah.
Thanks to Focus, we now also have a formal collaboration with the Miami-Dade Department of Health. And with them, we're able to differentiate between known, new, and out-of-care positives, and work closely with them in order to link these patients into care. So our program has achieved systemic change, and now we're able to find a program at every single emergency department in our health system.
It's just an incredible model. I love your focus on acute, new, and out-of-care positives. Dr. Panacos, many locations reduced or stopped screening for HIV and hepatitis C during the COVID pandemic. How were you able to deal with the COVID-19 pandemic and still maintain screening for HIV and hepatitis C at Jackson Memorial?
That's a great question. As the COVID-19 pandemic began surging through the country and affecting South Florida and Miami, testing and caring for these patients obviously became a priority in our emergency department. So we began focusing on developing protocols for screening, for testing, and for the care of COVID-19 patients. But the key component of our focus program that allowed us to continue screening for HIV and hepatitis C was the way it was developed since its inception. It is seamlessly integrated into our normal ED workflow. It's automated within our EMR, our electronic medical record system. I think without this, a lot of the manpower and resources would have been shifted towards COVID-19. But because it's hardwired into our system, we were able to continue screening for HIV and hepatitis C at the same rates as prior to the pandemic, which is about a third of our ED volume. We have seen the incredible impacts that this program has had in diagnosing patients early on in their disease process and linking them into care. So it was really important for us and also for the community that we continued screening and linkage through the COVID-19 pandemic.
Yeah, and I think since our program is so vital to the community, we really did our best from the very beginning to mitigate any barriers for linkage. So back in early March, which is when the pandemic started in the US, we leveraged a standing monthly meeting with the Department of Health to kind of address some of these issues that started coming up. For example, there was the linkage to care forms, and these are kind of like a contract between us, the patient, and the providers that enable us to share personal information and disclose some of their personal and results. So we were able to work with the county to receive approval to be able to send these electronically instead of having to physically give them the form.
Awesome.
Yeah, and we also had a case for an acute HIV person that was also co-infected with COVID. So this was at the very beginning of the pandemic, and it helped trigger the need for DOH to assign somebody to us so we could work together on a daily basis to not only confirm COVID status, but use telehealth to be able to link them into care.
I love the focus on collaboration with the Miami-Dade County Department of Health certainly seems to have helped you with your results and streamlining notification and linkage. Do you recommend this type of collaboration for other partners?
Absolutely, Derek. I mean, our formal collaboration with the Miami-Dade County Department of Health is through a memorandum of agreement. They are in-kind contributor to our focus project, and we have really great partnership going on. They also fund our linkage to care specialists and confirmatory tests. So we are extremely grateful for the continued support.
And it really does take a team to make this happen. So we're really grateful also to Gilead and the Department of Health, because without their funding and support, we couldn't sustain the screening program. The Department of Health has also expressed various times how grateful they are that we were able to continue testing for HIV and hepatitis C during COVID, because many of the testing programs in the community had to stop due to limited PPE, repurposing their staff, and social distancing requirements. So it was really important for us to keep this vital program alive and continue it throughout the pandemic.
I love it. Dr. Panacos, how has data played a role in improving training and screening for linkage to care for HIV?
Yes, we're always seeking ways to improve our screening program. One of the biggest challenges that we encountered after starting the program was reaching patients that had already left our ED prior to learning about their diagnosis of HIV or Hep C and linking these patients into care. So we thought of innovative ways to utilize our EMR to overcome this new challenge. And we created a re-engagement alert system that notifies our linkage to care specialists anytime that a patient returns to any sites within our healthcare system. This is actually a real-time alert. So they're able to be immediately dispatched to the patient's bedside to disclose the diagnosis and then to link them into care as well. By utilizing the EMR, we're actually able to link about 165 additional patients that were positive for HIV or Hep C. And we're actually in the final stages of disseminating the details of that alert system so that other projects that maybe face similar challenges are able to replicate it.
Well, let me say thank you and congratulations to this team. You're doing such an incredible job using data to do continuous quality improvement. And I am just so excited about this opportunity to get some of your best practices out to the community, the global community, so that we all can learn and benefit from public health goals globally. Thanks again.
Awesome. Thank
Thank
you,
you.
Derek, so much.
Thank you very much, Derek.
You're welcome. We couldn't come to Miami without paying a visit to Dr. Hansel Tukes. Dr. Tukes is the assistant professor of medicine at the University of Miami, and he launched Florida's very first syringe service program. I'm so excited for the viewers of this session. You're going to learn community best practices for integrated screening in HIV, HCV, and SARS-CoV-2, which is the cause of COVID-19, from a man who I believe has one of the biggest hearts in the field. We're so fortunate to have him. Welcome, sir. Welcome, sir, to this session.
Thank you, Derek.
Dr. Tukes, your work is so important. The people that you serve are some of the most vulnerable in our society. Many of them have little access to the healthcare system. Has COVID-19 made it more challenging to reach those who need the help the most with screening and linkage to care for HIV and hepatitis C?
Absolutely. I mean, just like coronavirus changed everybody's lives, it's had multiple effects on the community of people who use drugs. So one, we know that everybody is feeling anxious. The former First Lady, Michelle Obama, said that she was feeling a little depressed. We all have these emotional feelings right now.
Right.
And a lot of people default on substance use. So even people who were in recovery have returned to using drugs, and people who are using drugs are using more. And at the same time, as we have all of this nationwide despair, we had to cut back services at the needle exchange program. And that's
Yes.
because initially we didn't know exactly how SARS was transmitted. We didn't know how to best protect our staff and
Right.
how to best protect the people that we serve. So initially we cut back on we suspended actually our HIV and HCV testing for a month while we procured PPE,
Yeah.
both for our staff and to hand out to our participants. So that's masks and hand sanitizer. But as you know, Derek, when you're dealing with high priority and vulnerable communities, a lot of our work was a smile and a hug and all of these
Sure.
very human things. And unfortunately, COVID changed the face of harm reduction forever because it really took away those intimate moments of a smile and just the touch from another human. And so that's been really hard, but we were able to reinstate our testing. We're doing the HIV and hepatitis C screening. We have paired it with rapid coronavirus screening as well. And we've been able to reinstate that, and we've adapted. So now if somebody tests reactive for HIV, we're able to initiate them in care via telehealth. So just like I'm talking to you here now from my apartment, I'm able to do the same thing from the needle exchange program.
Man, you just said a mouthful. We're going to break all of that down. I think it's significant for me. You know, I think we both come from academic backgrounds where everything's about a p-value less than 0.05. And to hear you talking about kindness in medicine is so refreshing. And I'm just really looking forward to your leadership in medicine. You dedicated your career to harm reduction and to HIV. Your activism has led to statewide expansion for syringe service programs in Florida, which is outstanding. And we'll talk a little bit more about that a little bit later. Do you see even more opportunities for activism during this crisis?
Absolutely. So there are many things that changed during this crisis. So
Yeah.
to enroll somebody in Ryan White in order to cover their HIV care and enroll them in the AIDS Drug Assistance Program used to be a very laborious process where there were appointments and waiting times and
Yeah.
in stigmatized areas. Now we're able to enroll somebody in both Ryan White and the AIDS Drug Assistance Program with a couple of emails and a signature, and we're really able to initiate care in the context of the fewest barriers that I could have possibly imagined in the public healthcare system. So all
Wow.
of these steps that we've taken in the right direction to remove barriers, we have to remember after COVID that things should remain this way. We can prescribe buprenorphine, the life-saving medication for opioid use disorder, without seeing somebody in person now. We can do it without urine drug screens. All of this progress must remain after COVID. We shouldn't go back to this whole punitive model of you have to wait in a line just like you're waiting for bread, you know, in order to enter HIV care. We should be a hospitable environment, and we should bring the care to the people, and that's what harm reduction is all about.
Dr. Tooks, I'm reading a book called Crucial Conversations, and I have been reading one line over and over again, and it says, "Nothing fails like success." And I had to read it over and over again to understand that basically, you know, you get a crisis or you get a challenge and you rise to it and you get success, but then nothing fails like success. And COVID has shown us that whatever success we had, we've got to take it to the next level and continue to be nimble and innovative. And your work is such an example of that. We need to make sure that some of these new practices that you bring up don't go away. Tell us how you've been able to continue screening and linking people to care during this COVID-19 pandemic.
Yeah, so just like everywhere else that people access the healthcare system, when people want their routine screening at the needle exchange now, we do a temperature check and we ask them if they're experiencing COVID symptoms. And then when we do our point of care HIV and HCV screening, we also do point of care SARS-CoV-2 for both the acute and the IgG antibodies. And we've paired that all together. And if somebody tests reactive, now with this telehealth framework that we've established, we're so fortunate that I've always worked in my research career at trying to lower barriers. And previous to the pandemic, I had really hedged on using telehealth to reach vulnerable communities. So when the pandemic hit, we were ready to go. And so the fact that we can just turn on the monitor and I'm right there, whether that is at the needle exchange, on the mobile unit, or even in a homeless encampment in rural Miami in Southwest Dade. We're
That's amazing.
really able to take the care out of the clinic and bring it to the people. And that is key to diagnosis, is really bringing the care out of the clinic and ending the HIV epidemic goals.
Yeah, you speak with such simplicity, but it's such a model of innovation and, again, being nimble. I remember when you started the Idea Exchange some years ago, the syringe service program there in Miami, within weeks, you discovered an outbreak of HIV and hepatitis C in a homeless encampment. Your team has published several manuscripts over the last few months, and so we look forward to reviewing those, and congratulations to you, and good for the field. You mentioned there might be silent outbreaks if there are deficits in screening and harm reduction services. Could you say a little bit more about that?
Absolutely. So the thing about the harm reduction community is we're a huge network, and we rely on our colleagues in other cities worldwide when we're making programmatic decisions. So I'm very much a Twitter voyeur. So when I saw what was happening in Europe and Asia, I was very concerned. So very early on at the Idea Exchange on March 17th, I believe, is when we decided to suspend testing. And that was based on the feedback that we were getting from the programs in New York City and Seattle, that over the majority of programs had suspended in-person testing due to the risk of transmission. And that made me very concerned about the risk of silent outbreaks occurring of both HIV and hepatitis C, with the majority of programs no longer screening. Because as you mentioned, when we started our routine screening program at the Idea Exchange in Miami, within 6 months, I believe there were 11 confirmed seroconversions. And that was very concerning because it was within a 2-block radius where all of those people lived. So the importance of routine screening in populations that have repeated exposures to HIV cannot be understated.
Your work has certainly proven that integrated screening can happen in vulnerable populations, what I call need to reach populations, because we've got to figure this out. Your work, Dr. Tukes, has led to policy change, reminding us that there's an incredible connection between data, advocacy, and policy. And really, most importantly at this time, policy that protects and also prepares us for crises like COVID-19. So I think I'll end with just the biggest thanks from Focus and also from the community. Thank you, Dr. Tukes, for all that you do.
Oh, thank you for your support all these years.
You're very welcome. So for the last decade, Focus partners have established a model to operationalize national and regional public health guidelines and recommendations as it relates to screening, diagnoses, and linkage to care for HIV, HCV, and HBV. By now, many of you, as you've listened to these sessions, better understand that Focus has 4 tenets. That 1, testing be integrated in normal clinic processes and flows. That you would use existing staff and infrastructure to create greater efficiencies. Secondly, that you would maximally use the electronic medical record. And then have some systemic change through stakeholder engagement, both internally and also with collaborating community. And then finally, that there will be training. Training involves data and continuous quality improvement with iteration of that data and dissemination. So excited to be introducing you to someone a little later who has really exemplified that and done that really well. It was in 2018 that we tested the application and transferability of this model outside of the US internationally. And we just had the fastest virtual flight ever from the US, and we find ourselves in Portugal. We are in about 30 miles west of the capital city in Cascais, and we are here with a fantastic partner who launched Focus's first work outside of the US. So I'd like to introduce you guys to Dr. Inês Vaz Pinto, She's the project's principal investigator. She's been with the project since day one on the ground, and it's just so incredible to see Dr. Anish.
Hi, everyone. Thanks, Derek.
I love it.
Yeah.
I'm actually, before you get started, I got to tell you, I'm looking at a picture of you outside the hospital, and over the picture translate, no hesitations, getting tested is easy, living in doubt is hard. And you guys have been so bold about your work. I can remember being there and seeing big posters throughout the hospital, 90-90-90. You guys have just, you just went for it. You implemented the project in 2018. So please tell a little bit about the driving force for you as an ID doc, an ID specialist in routinizing screening for HIV and hepatitis C.
Okay, let me just correct you a little bit. I'm an internal medicine specialist, and I do
wrong.
HIV
Thanks.
medicine. I prefer this term. Really, the Cascais Hospital, where I work, we have been involved in the European testing weeks that occur in November every year, and we had the luck to have the board help us and encourage us with those initiatives, and that's why you saw so many information around the hospital about testing and HIV. And if you see, if anyone can see, we had these things on our white things that we use saying, "I did my test, have you done yours?" And a lot of those things. Okay, and so we were also very interested in HIV diagnosis and testing, but unfortunately, HIV testing week is not enough. And we were very fortunate to be chosen as the first partner in Europe of the Focus project. And so since September, when the project was launched after much preparation, what happened exactly was that there were changes made to the electronic medical record so that when patients came to the ER, they had automatically the serologies for HIV and HCV. We decided not to do HPV here because it's not very prevalent. They had those serologies automatically inserted in their blood requests. So what happened is the doctors don't, it's like Focus works, the doctors do not request the tests. It's an automatic system for everyone who's between 18 and 65, which is the according to our national guidelines. And a very important thing is it's included for the patients who have a requisition for blood draw. No one was ever had their blood drawn just for this project. It's been amazing, really. We started in September 2018. It was very exciting to start receiving the first results. And when we looked at the results in a more detail, we looked when we had about 16 months of the project going on, and we saw that we were really making a lot more diagnoses in the ER when we compared to the same period of months before. It was amazing. So we had a lot more diagnoses done, and most importantly, we were able to start to diagnose patients much earlier in the course of their infection. And we had the perception that patients who then were linked to care to us. For a lot of patients, we felt that they would never have had an HIV test if they didn't come to that emergency room on that day. And this is very important because it was a way of, in the months before, we were very excited, also preparing ourselves to this community, this city, which is close to Lisbon, And we were very enthusiastic with other organizations in the field to prepare for being Portugal's first fast-track city. One of the assignments that the hospital had committed to was to increase testing to help the first 90 goal of UNAIDS. Because and we made it through implementation of the Focus project.
Dr. Anish, your statistics on early diagnoses are incredibly significant and so important for the field. You know, I think about the first, again, for the UNA's goals for 90-90-90, that first one about diagnosis and screening and linkage to care. You operationalized the Focus model to make that happen. Your work takes me back to when I was practicing, and it was really only through routine screening that I ever got a chance to meet a man or woman who wasn't AIDS defined. I could meet people who had higher CD4 counts who were asymptomatic. We could get them linked to care because there was this routine screening program. So I think it's so important to so many of our global goals for HIV that we have programs like this. I think your work is fantastic. Our Focus partners have shared multiple lessons on routine policy-driven screening and linkage to care for HIV and HCV in the era of COVID-19. Jackson Memorial Hospital highlighted the importance of automation to identify and link in real time HIV and HCV infected patients who are out of care and accessing services at their location. Many have and will continue to debate our global preparedness for this crisis. But San Antonio's Metropolitan Methodist Hospital showed the importance of preparation. A sound infrastructure built in 2019 prepared them to address HIV and hepatitis C during a challenging surge of new cases and death from COVID-19 in their region. The University of Chicago highlighted our opportunity to identify acute HIV, as many sought healthcare for suspected COVID-19 respiratory symptoms, but were actually experiencing symptoms associated with acute viral syndrome. Had they not been testing, these patients may have been missed. COVID-19, HCV, and HIV impact our entire community, including and disproportionately the most vulnerable in our population: racial, ethnic minorities, migrant populations, IV drug users, and the homeless. Our partners in New Orleans, Miami, and Portugal established integrated policy-driven approaches that allowed them to address HIV, HCV, and SARS-CoV-2, the cause of COVID-19, with equal priority in their community. Finally, Portuguese partners at Hospital of Cascais demonstrated that a routine policy-driven approach in high prevalence regions facilitates a decrease in late diagnosis, which, as we stated in the opening, has significant public health benefits. It is crucial that we prioritize our investment in HIV and HCV screening and linkage to care. I trust that you've gained some valuable tools to address HIV and hepatitis C in your city in the era of COVID, and I'll end with just saying obrigado and thank you.